heard Judah Folkman give our Presidential Health Science Center lecture on
Thank you. Good morning. One of my hobbies is music, and they always say never follow a better piano player. But I have that task this morning by following Ian Thompson. Let's see if I can get your slides off and get my slides up. While I'm doing this, I'm going to tell you I'm not a part of the prostate mafia. This morning, throughout this conference, you're going to be, as Ian said, you're going to be exposed to some of the thought leaders in prostate cancer, the prostate mafia. And they know more about prostate disease than anybody on the planet. This conference is great from that perspective. But this is a conference on aging. And I think it's very important that all of you recognize that we're talking about this disease within the context of older men. So Mike is right. I'm here to get your feet on the right path, get you oriented, because that is where I am part of the aging mafia. So we got two mafias coming together. I have been conducting research in aging and the development of frailty for the last 15 years. That is my interest. And I became interested in prostate disease because that is a near universal phenomenon in men with age. And what that means, how that is a marker for the development of frailty, and how it relates to other aspects of aging and function is where my interests lie. A year or so ago, I teamed up with Ian and colleagues in urology, and we got a grant from the CDC to go out and educate primary care providers in the pros and cons around the controversy surrounding prostate cancer screening. As most of you are probably well aware, the clinical guidelines are in conflict. There's uncertainty everywhere. And so the CDC wanted to have a package that could be used by people who are not experts to make decisions, because every day across the country you've got a man who walks in and talks to his doctor. Either he brings the issue up or the doctor brings the issue up. What do I do? And then the conversation takes off from there. So my colleagues Roy Jones and Lorraine Babcock, who's standing in the back there, and I have been traveling around the country talking to primary care providers about this issue, and guess what? You think you're confused. The non-experts are really confused about issues in prostate cancer screening. Before I start talking, you have a blue sheet that looks like this. I want you to fill it out, pass it in. This is one of the surveys that we've been doing with our providers, and I'll show you a little bit of that data. So I'm using this as an opportunity to collect some information from you. On the back is an orange sheet that I also want you to fill out, particularly if you're a provider in the 4-county region around San Antonio. And I'll talk to you about what that means a little bit later. So I want to lay out some ideas that have emerged from those series of workshops. I've talked to physicians at the National Medical Association. I've talked to primary care providers here in San Antonio who've come for recertification courses. We've gotten a spectrum of people who are wrestling with this idea, wrestling with these questions with their patients, and the results are really, they're interesting, they're scary, and pretty thought-provoking. So why should we focus on primary care? Because men come in intact. They don't present to a urologist. They come to see their primary care docs. They're not just a prostate, they have hearts, they have cholesterol, they have hypertension, they do all kinds of things. They have brains that have strokes. And all of that is seen first and foremost by their primary care providers. So that's why we're focused on primary care. As I said, prostate cancer is a geriatric issue, so I'm going to touch on some of what I think the geriatric issues are. One issue that's come up in the workshops is competing demands. In this conference, prostate cancer is king, but I can tell you, in the world of primary care, prostate cancer is not a high priority item. And we're going to talk a little bit about why that might be. The other thing that came out in these workshops is they're very different physician experiences with cancer across the country. And we're not talking about experiencing treating patients, we're talking about the environment of cancer in which a primary care practice is set up. And that has a really big influence, I think, on the way prostate cancer screening is processed by docs. Okay, so what's the geriatric issue? Number one is optimal function. My geriatrics people will immediately recognize this. This is one of the, I think, seminal concepts in medicine that is emerging at this point in time. Historically, we have been focused on mortality because if you die, that's the end of the ball game. Well, people aren't dying anymore. Ian showed us some wonderful slides on demographic shifts. So now an important outcome in any treatment, not just prostate cancer, but any treatment, is optimizing function. It is not enough that a person survive a stroke. It is not enough that they survive a cancer episode. It is, what is their functional status like afterwards? And in geriatrics, that has implications for independent living, it has implications for family structure, it has all kinds of cost implications. So function is a geriatric issue, and function in prostate cancer, some people call it quality of life, matters. And you'll hear a wonderful panel, Carol Moynpour sitting back there, is going to talk about that later on this afternoon. But function, if you learn nothing else today, think about the word function in all that you do, because it is an important geriatric issue. Now, why is it? We've said, I like the word old because that's what it is. Mature, I'm mature now. I'm not old, but I'm mature. Why is function important? Because not only are people living longer, but guess what? They're living better. They're living in better health than they ever were. Today's 70-year-olds are in much better shape than they used to be. What I'm showing you here is a slide that we developed using life expectancy data and combining that with a concept that we have in geriatrics called active life expectancy. And what active life expectancy does is it estimates the number of years that you will live free of disability. And so what we did, this is from Eileen Crimmins' work out at University of Southern California. She looked at men who were age 70, 80, and 90. And what she did was estimate if you had a 10-year life expectancy at age 70, which is much, when she did this paper, it was 10 years. It's beyond that now. And she parsed it out into years. If you made it to age 70 and you had no functional problems, which many, many, many of our 70-year-olds do, how many additional years would you live in that same state? And what she came up with was an estimate of about 4 years. The next stage, some functional problems, meaning you might not be able to do heavy housework, or you might have some limitations in shopping, but you could still live independently. Well, there's an additional 4.8 years that you would live in that state. So that 10-year period already, we're talking about almost 9 years in a very quite high functional level. Only about a little bit less than the last year of life at age 70 is spent in a state where there's no ability to engage in self-care. That means bathing, dressing, and requires support. So that's why function is important. It's even more important because guess what, folks? We're raising the retirement age. We have to. Our country will go broke. So people who have diseases, and I consider prostate cancer actually to be a chronic disease. It looks that way in the geriatric population. These people are working through a part of their lifespan where they may be walking around with a diagnosis of prostate cancer. They have to be able to carry on these activities. The treatments that we come up with cannot interfere with the ability to live independently, or shouldn't. If you look at guys who are in their 80s, same sort of story. There's a smaller proportion of life lived with no functional problems, but still, there's about 85% of that expectation of life with little or no functional problems, so that people can live independently, and at age 90, same sort of story. Now the chunk where you need personal care gets bigger, but function is the name of the game. Now the thing you also need to understand, and this was something that our primary care docs were amazed at. If you look at some of the recommendations, there's a group that advocates stopping screening when the life expectancy is 10 years. How do you know when the life expectancy is 10 years? Can you look at someone and make that estimate? No. You can't even look at the data and make that estimate, because in the last, since 1980, the life expectancy for a male age 70 has increased by 20%. So we may be carrying around more clinical labels, but we are certainly living longer. And we are living with less disability than the folks who preceded us. So the prostate cancer story, and cancer in general, in an older adult population has to be put into this functional context. Okay, so what does that mean? Well, that means prevention is an issue for older adults. Now, there'll be a talk on prevention, prostate cancer prevention, that's coming after me. And that is mostly focused on sort of what we call primary. I'm going to use this to sort of review levels of prevention with you. Primary prevention is basically you're trying to prevent the disease. Well, in geriatrics, we've come to understand there's other kinds of prevention that can be engaged in. There's secondary prevention, where you detect the disease early and arrest the progress. There's tertiary prevention, where you minimize the impact of the established illness. And all of those endpoints can and should be part of your thinking on prostate cancer. So even if someone is cognitively impaired, and this is a discussion we have had in some of our primary care groups, if you suspect someone has prostate cancer, they give you signs and symptoms of prostate cancer, it is worth your while to test them for it. Why? You're not going to cure it, but what you're going to do is minimize the impact of an established illness by identifying someone with prostate cancer, treating the cancer, because bone metastasis have the potential for interfering with mobility. Chronic pain is not something you want someone to live with. You can treat that with radiation if you know the cause. So tertiary prevention becomes a very big issue in geriatrics, whether you have a guy who's 70 and walking the golf course, or someone who is being cared for by family. And I can tell you, we've had in our geriatrics clinics, we've had families who do not want to treat older adults with cancer because, oh, they're going to die, or the thinking is somewhat fatalistic, not recognizing that untreated cancer has grave functional consequences, which can be avoided with really good and sound treatment. The graphs here are just sort of a graphic, some people like words, is a pictorial way to get you thinking. Prevention is an important part of primary care at any age. You can teach an old dog new tricks. Tertiary prevention becomes really important among older adults, but throughout the life cycle, prevention is an important piece. It's just you have to be clear in your own mind what it is you're after to try and prevent. Okay, so those two are sort of the big geriatrics issues. Now I'm going to move a little bit into the primary care issues and give you a flavor of what I've been learning. I haven't had a chance to write this up for publication yet, so I can't put you onto a paper that we've published, but we're working on it. So you guys are getting the first pass on what we've been learning from these workshops. And the one thing that comes to the fore with the primary care docs is competing demands. So I'm going to start out by telling you the research on prevention says that there's opportunity there to do prevention, because at any given year about 75% of Americans are seen by a physician. So the opportunity is there for most of us to have some kind of preventive service, but in general it's not done. It's not up to date. 20% in some cases, 60% in others. Any preventive service, we're not talking about prostate cancer, but just any preventive service. Last December, we took, Lorraine and Leroy and I have been reading and looking and talking, and we presented this model that I'm going to walk you through to sort of get at testable, researchable issues in geriatric primary care and how the regulatory environment creates barriers to care. And you can think about prostate cancer in these ways, because I'm going to show you some scenarios. In the center of all this, of course, is the primary care practice. This is where the rubber meets the road. If you're going to get care, if you're going to enter the healthcare system, this is the door that you walk through. It's very rare that a patient walks directly into a urologist's office, unless they're a physician and they know what's going on with themselves. Most of us walk through primary care practices. And the practices, of course, have a structure. They have a panel size, they can be public or private, they have staffing, and they have to think about funding sources, and they have to respond to the clinical guidelines. There are policies out there, rules and regulations that affect the practice and are affected by the practices. There's the demographic imperative in size of the population at risk, age, minority status, and levels of frailty. And all of these come together to generate cost factors that influence what's happening in the practice. Time with patients is actually gone up. Their papers have been published recently. Doctors seem to be able to spend a little bit more time with their patients in primary care. There's a ton of paperwork out there. You would not believe how many conversations we've had about the amount of paperwork that has to be done to take care of someone. And of course, there's always the revenue demands. Most people in geriatrics practice run their practices so that they can break even. Geriatrics care, I will tell you, is not a money-making opportunity. So most of the people who we've talked to are just trying to stay afloat so they can meet the demands, pay their staffs, and keep their businesses running. So this is the model. If you apply it to the problem of prostate cancer screening, now we're not talking about taking care of people with prostate cancer, we're talking about screening here. We've come up with two scenarios that are supported by some indirect studies that have been done. There's one study called the direct observation of primary care, where they actually had nurses go into the practices, observe the doctor-patient interaction, make a note about whether or not prostate cancer screening took place, and then validated it. So we have some really good studies on this side of the house. So in a scenario where there's a high likelihood of being screened, the practice is usually a group practice. There's a moderate patient volume. What that means is they see about 3 or 4 patients an hour. The politics is the same. This is one constant that operates at the state level. For example, in Texas, prostate cancer screening is a state mandate. It's unfunded, but it's a state mandate. And it wasn't until 1997 that state employees came under this umbrella. Before then, and I am a state employee, I work for the University of Texas, our insurance policy did not cover it. And there's, of course, the insurance regulations. Now, most states we've looked at have some sort of coverage for prostate cancer screening, but in places like Oregon, it's very prescriptive. You will screen certain people under certain conditions and other people not under other conditions. So this varies by the state level and by the private company, and that has an impact on the practice. The case mix of the practice has an impact. If the case mix includes mostly relatively young, well elders, and I'm talking about people who are between 60 and about 75, then what we propose is that the patient demand for the service will be there, that the cancer risk will vary, but the test reimbursement is probably reasonable. So this is a scenario where you will see relatively high rates of prostate cancer screening. Okay? All right, and write your questions down, because I'd be interested to hear what you think about these scenarios. Now, this is a second scenario where there's a low likelihood of screening. The regulations have not changed, because both of these practices, let's say, live in the same city, maybe different neighborhoods. Practice structures that don't seem to have, or have low rates of screening are, again, group practices. Most states in this country have gone to a model of group practice. Now in Texas, it's fascinating. I've looked at the data for Texas, and anywhere from 1/3 to 60% of our physicians self-identify as solo practice, depending upon the county. In Bear, it's about 1/3. In places like Comal, we got any people from the area? You know Comal? Anybody from Comal County here? Or Guadalupe County? Or Kendall? Okay, well they have high rates, I will tell you, out there of solo practitioners, which are almost unheard of in other places. So I've got group practice here, but the solo practitioners could fit in here very well. The practices that have low screening probabilities have high patient volumes. They see anywhere from 5 to 6 patients an hour. They have patients, and their patients have a single payer, and it's usually Medicare alone or Medicaid. They don't have supplemental health insurance. So even though Medicare has a benefit, you should know that about 20% of primary care providers will not take a patient who has Medicare only, because Medicare does not pay for the services that people consume at a level that can sustain the practice. The president of the Texas Academy of Family Physicians was quoted with that statistic in March in the Sunday New York Times. I always stand at the countertop in my kitchen and read the Sunday papers, and I almost choked on a bagel when I read that. So you too can find that. So having Medicare does not get you in the door the way we used to think that it does. And there are people out there in the older age group who are dual eligibles, meaning they get Medicare and Medicaid because they have such a low level of resources. Those people are being seen mostly in practices like this. And those practices have high numbers of frail elders, people with chronic illnesses. And basically those practices provide a service to those people. So they don't have time for screening because they're too busy with chronic illness management. There may be moderate demand for the service. The patients in general in these practices don't demand to be screened. There's probably a high cancer risk because this is a group, it can be populated by people with low levels of income and all the risk factors you can imagine for cancer in general. And they are covered by things that are companies that give them low test reimbursement rates. So this is one scenario for low levels of screening, and one aspect of prostate cancer screening that we're doing more work with. Okay, so that's sort of the competing demands piece of prostate cancer screening. Now I'm going to spend a little time now and talk to you about what we've gotten from the workshop that tells us there are very different experiences by primary care physicians with cancer. As I said, we've talked to people at national meetings, we've talked to people locally. We've gone and done Friday afternoon seminars with groups of doctors who practice here for the county. We've got really quite an interesting spectrum. And these are 3 points that jump out, at least for me. 78% of these guys have never seen a biopsy performed. They all went to medical school. They've never seen a biopsy performed. And what is related to that question is their fear that by initiating a screening process, you expose a patient to something else that's going to hurt them. We've had people share stories about, my patient had a biopsy and had a heart attack on the table afterwards. That's how decision making, independent of, in an atmosphere of uncertainty, physicians are forced to make decisions based on the last case that they saw. That is a time-honored psychological method for making decisions. So if you've never seen a biopsy, you're going to make decisions on sort of indirect evidence. So one of the things we've done with the workshop is we now have videotapes, video clips of an actual biopsy. And they see the patient is comfortably laying on the table, they see the whole process, they see that anesthesia is given. I don't know if it's going to make a difference, but at least this is the way we responded to that one. In our surveys now, hopefully all of you have filled out your surveys and you're going to return them. 17% of our sample, we're now almost up to 100 docs, admit that they do not perform DRE. Those are the ones who will admit it. I'm sure there are others who don't do it, won't do it, and won't admit it. And when we've talked about it in some of the groups, there is a feeling that it is not clinically useful, is what guys will say. There's no evidence to support it. Other guys will argue it is standard of care in some communities, and if you don't do it, you'll get sued. But that's the way the conversation goes around DRE. So if we're going to think in terms of screening, and this is one of the cheapest, easiest gateway procedures, and you got almost 20% of guys not doing it, we've got a problem with detecting what prostate cancer is out there. The last question, I had a checklist of attributes that are, and I've asked, we've done this checklist with medical students and residents and all kinds of people. What we're trying to get at is sort of attitudes toward aging in general, how you think about older adults. And so it runs the gamut from physical signs and symptoms like gray hair to attitudes like conservatism. And embedded in there are a couple of prostate-related questions. 24% of our docs feel that prostate disease is normal aging. Now, I will tell you, those of us who do research in aging and who have been in it for a long time are coming to understand that that peculiar degeneration that we undergo with time is itself a disease that can be, if not halted, then delayed. And some of the data that Ian just showed you about caloric restriction is one of those ways. We now know that we can put off some of the problems of normal aging. So if your healthcare provider feels that when you walk in and complain about symptoms related to prostatism, if he or she believes that it is normal aging, then that influences the likelihood of screening, independent of anything else. Okay. Something we've gotten into recently, because we're about to mount the second year of this CDC grant focuses on local docs here in Texas. And so we've started to go county by county after the primary care docs. And the first thing we looked at were the county level prostate cancer incidence rates as a measure, as an independent sort of environmental measure. And what we've seen is there are very, very big differences at the county level in prostate cancer incidence. And this may have an impact on whether or not you want to screen. Now, we'll tell you, here in Texas, we've gotten money from the CDC to work on our data collection efforts. And that money, I've talked to the folks at the Texas Cancer Council, and we are pretty pleased with the data that I'm about to show you. So this is not, what you're looking at are not, strictly speaking, data fluctuation issues. What you got here is time trends. This is between 1990 and 2000. Age-adjusted prostate cancer rates for the 4-county area including San Antonio. So we got Bexar County. My husband pronounces it bizarre because he thinks that's funny. Comal County, which is straight north. If you're going up I-35 to Austin, you drive through Comal County. Guadalupe County is north and slightly east of us. Kendall is north and slightly west. Guadalupe County is where Seguin is. Kendall County, well, Comal has New Braunfels, but Kendall and Comal are big retirement. You can think of them as Texas Hill Country counties. So they're very different in populations there. Now what we did with the graph, the straight line across the middle is the Bexar County rate. And all the other counties are compared to Bexar County. Why did we use Bexar County as a standard? It's home of the university. We have all these smart doctors. We do clinical trials. People like Ian and I live here. You know, we drive the intellectual environment of this county. So every time a line goes above 1, the cancer incidence rate in that county is above Bexar County. And when it goes below 1, they have less. So if you look, Guadalupe County is in red. It's this red line. Most years during this 10-year period, Guadalupe County had prostate cancer rates which were significantly lower than Bexar. We've tested them, they're lower. The average age in Guadalupe County is 30. It's a young population by all demographic standards. So if you're practicing, and there are 31 primary care providers in Guadalupe County, they don't see much prostate cancer. We will find out as the research proceeds, may have a different perspective on prostate cancer screening than their colleagues who practice in Kendall, which is this sort of dashed line here. Most years, Kendall County had rates higher than Bexar. This was, I think they had a fire in the records office that year, so the data are not good for that year. But you can see, and the average age of the population in Kendall County is 38. That's a big difference. Much older population in Kendall. And I don't know if you can see the yellow, because it's hard to see from over here. But Comal is somewhere in between. A couple of years they're higher than Bexar, a couple of years lower than Bexar. And so it's in the middle. And so if you were to make a guess about who's likely to screen just by the county that they practice in, like I said, 31 primary care, licensed active primary care physicians in Guadalupe, 31 in Comal, and 48 in Kendall. We've looked at the Texas licensing directory. Those guys may have very different opinions about prostate cancer screening. We're going to find out what they are. So what's the bottom line here? As you go through the day and you go through tomorrow, think about primary care, because before you can get to brachytherapy and before you can get to all the fancy stuff that you're going to hear about, which is wonderful, which is needed, you're going to have to get through the primary care door. And you're going to have to get a handle on how prostate cancer influences active life expectancy. That is part of the decision process that we are getting from primary care providers, even though they don't call it that. We're going to have to understand that older men have multiple chronic disease risks, and that in the primary care setting, they're trying to balance, their docs are trying to balance care for all of that. If your cholesterol is 300, am I worried about your prostate cancer? Well, maybe I should be, but maybe I'm not. So where does screening fit in, and how can we make it manageable? And the last one, which I think it will be a nice new, I'm very excited about doing research in this area, where does the practice fit into all of this, and how does the practice's experience of cancer, prostate cancer, influence how they behave? This question is relevant in geriatrics practice because we're starting to understand now that the practice's experience with older adults, the practice's stability, all influence the quality and the intensity of care that a geriatric patient can experience. And I suspect it applies to the problem of prostate cancer. So I'm going to stop talking now and take any questions. Thank you for your attention this morning.
I think we have time for maybe one question, and since we are running behind, we'll take after one formal question. Maybe Toni can take some questions here while we take a break, and maybe we'll truncate that by 5 minutes. Are there any questions?
Yes, sir.
How have you found that the format of educating primary care doctors with this almost debate pros and cons has worked as opposed to just, I think that's the way you're actually educating, where it's a...
Jones and I, yeah, the way the workshops are structured, Dr. Jones is a urologist and I square off, although it's not as adversarial as he bills it. We talk about the pros and cons. We talk about the downside of screening as well as the positive benefits. So they hear both sides almost as a debate, and it was modeled after something that Ian and Otis Brawley like to do. That format is actually a wonderful process. What we've done is we've brought the primary care docs into it. We've actually had docs stand up in the audience and square off with each other. That's a lot of fun. What I really enjoy the audience participation piece of this. We've had guys, when we've talked to the National Medical Association docs, they were concerned that the policies block screening of younger men because they've seen prostate cancer in guys in their 30s. We had guys at the American Geriatric Society meetings who absolutely wanted to throw the tests out the window. And what's wonderful is everyone who has an opinion is passionate about it, whether they have data to support it or not. So it works, because it gets people activated, and that's what I want. Yes, sir.
With respect to primary care physicians, most of us do agree that the DRE gives very little valuable information towards the detection of cancer. But that's not the only reason to do the rectal examination, okay? First and foremost, you'll get the information on the health and status of the prostate. You'll get a feel for the health and status of the rectal area, hemorrhoids, chronic O, whatever. You'll get information sampling for your colorectal screening, okay? You do all of that. And fourth, and probably very important, it'll make you it'll make you look to the patient and the patient's family like you know what you're doing. Here's a doctor who really is up to date, okay? He knows what he's doing, he cares. And all you have to do is do it once a year. Now, I tend to do it during the anniversary month of my patient's birthdays. So every patient...
Happy birthday.
They don't have to come in on their birthday.
Okay.
They come in sometime that month. And they'll always know that they'll always be able to remember when my physical examination is due, when I had my last one. It gets them involved into their own health care. Okay. So there's more than detecting cancer.
Absolutely.
Okay.
Absolutely.
And as I said, the fourth one, it makes you look good to the families that you're caring for.
Well, yeah, and in the direct observation of primary care study, patients are able to remember having received the DRE much more than the PSA test. The nurses ask them after the interview, did you have prostate cancer screening? If they had a PSA and they didn't have a DRE, they'll go. If they had that DRE, they know it.
In my population of male patients, even those that are under 50, many of them do have already some other comorbid problems. So they too get their annual physical examination.
Oh, yeah.
And at that time, if nothing else, if you don't do a DRE, you can mention to them the risks that they run. Again, it makes you appear like a more thorough and competent physician when you at least discuss the possibilities of prostatic problems. But again, you have hemorrhoid and colorectal screening that you can also do.
Yeah, I've had this debate with some of our residents, actually, who argued vigorously against DREs, and what I tell them is that examining people is a privilege, and that this is part, that they expect you to examine areas that no one else would do, and this is a privilege.
What they don't realize, what they're not taught, is that DRE is more than just the prostate.
Right. That's right. He's right.
And they never see that. And if you can get them to see past the prostate, they can see where the DRE also benefits several other aspects.
Yeah. Yeah. Good point. Excellent point. Other questions, comments? All right. Well, thank you for your time, attention, and enjoy the conference.
Thank you. Thank you for putting a wise perspective on this conference. And I have 10:25. Let's come back at 10:35, if that's okay. And just as you're breaking, I'd like to acknowledge a number of organizations for their financial support of this conference. Merck & Company, AstraZeneca, Aventis, the John A. Hartford Foundation, Novartis, Pfizer, Purdue Pharma, and last but certainly not least, our own Vision 17 of the VA networks. So I'd like to thank all of those organizations, and there are some exhibits in the back.